Okay, so I would like to welcome you all to the annual Sternlicht lecture offered by the Department of Pharmacology. This lectureship was established in the honor of Robert Sternlicht, the son of Hyman Sternlicht, who was professor at the Department of Pharmacology. As several of you might know, Dr. Hyman Sternlicht passed away about 2 weeks ago after a very long battle with pancreatic cancer. The Department of Pharmacology faculty, as well as other members who know him well, are deeply saddened by his passing away, and he will be definitely be missed. We are all, however, grateful that members of his family, Mana, his wife, and son, Bradley, is able to attend today's lecture despite this difficult time. Hyman was trained in theoretical chemistry at Caltech, and he was one of the internationally recognized founders of carbon-13 NMR spectroscopy. But midway through his career, he decided to go through a more biological field and joined the Department of Pharmacology in 1977. He focused on looking at the understanding of microtubule assembly. His son, Robert Sternlicht, was a graduate of Case Western, and he majored in electrical engineering. He then obtained a master's degree in Georgia Tech, and then took a job at Rockwell International, where he worked on several contracts with the Department of Defense with distinction. Sadly, Robert Sternlicht passed away at the age of 27 from Hodgkin's lymphoma. After he passed away, this lectureship was established by his family and friends. And this has allowed us to bring, as you can see from the list, eminent scientists in the field of cancer therapeutics. I also say that Dr. Clark Distelhort was instrumental in setting up this lectureship along with the Cancer Center. We are hoping that this lectureship will be a important part of Hyman and Robert's legacy that his family will be very proud of, and also a testament to his continued devotion to scientific research. I'm very pleased to introduce our today's speaker for the lectureship, Dr. Daniel Haber. Dr. Haber obtained his Ph.D. and his M.D. from Stanford. His Ph.D. work was on resistance to cancer, the mechanism for resistance to cancer therapeutics, specifically looking at amplification of the hydrofolate reductase in cancer. He then took internships and residency at Massachusetts General Hospital, and then followed by a postdoctoral fellowship at MIT with Dr. Hausman, where he identified the Wilms tumor suppressor gene. He then took his first faculty position at Harvard Medical School, where he continued to work on W2 tumor suppressor gene, as well as other oncogenic mutation in breast cancer. In particularly, he was instrumental in identifying BRCA1 and BRCA2 mutations in early onset breast cancer, as well as characterizing the mechanism action of BRCA1. Dr. Haber is now full professor at Harvard Medical School, as well as the director of MGH Cancer Center. Just this year, he also became an investigator at Howard U.S. Medical Institute. He has received several awards, including highest awards of the Association for Cancer Research, as well as a merit award from the NIH. He oversees a research program that is very well funded and has very impressive publication record, consistently publishing papers in the top journals Nature, Science, Cell, Cancer Cell. In addition to his characterization of Wilms tumor suppressor gene as well as genetic predisposition for breast cancer, he has made important contributions to molecular genetics underlying cancer therapeutics, and that is going to be one of the major focus of his talks. I don't want to take too much from his lecture time, so I'm very happy to introduce Dr. Daniel Haber.
So thank you very much for this introduction. Thank you very much for the invitation to give this honored talk, and thank you very much to the Sternlicht family for coming to this talk and making this, this award possible. I'm very intimidated not only to be here, to be in a pharmacology department as a geneticist, but also to speak with the lineup that you've had for this seminar series in the past, so I'll try to do it justice. And as you may know, my lab has worked on a number of topics recently, and what I thought I would do for this talk is to give the talk of a geneticist coming to a pharmacology department, which is to primarily focus on the issue of these new targeted therapies in cancer, what we've learned about them, and how we can try to apply them to hopefully change the way that we treat cancer in the future. So what I thought I would do is start off by giving you a brief overview of some of our recent work on lung cancer and EGFR mutations, and then quickly go into 3 different areas which are relatively new. One of them is our studies of acquired resistance to these drugs. One of them is our strategy for trying to identify additional drug targets and potential therapeutic options in cancer. And finally, I want to end with a new technology that we've been involved in developing to purify circulating tumor cells in the blood of patients with cancer, which would again enable the kind of genotyping studies that I think will help direct the future treatments in cancer. So with that, let me start by starting with a bit of an inspiration slide. This is actually an article that came out in the Boston Globe, and it explains how, as a breast cancer and Wilms tumor researcher, I started working on lung cancer. And this was basically the story of a woman, a nurse with very, very advanced metastatic lung cancer, metastatic to liver and brain, who had not succeeded in responding to any chemotherapy regimens, and then was treated with this new drug, which was kind of coming on the market, an inhibitor of the epidermal growth factor receptor, EGFR, called Iressa. And magically, she had a complete response. And the tumor melted away. And this patient, Kate, is actually still alive now 5 years after receiving this drug with no evidence of tumor recurrence whatsoever. And the reporter for the Boston Globe basically wondered aloud why one patient like this would have a magical response to a drug when everybody else who seemed to be getting this drug actually seemed not to respond particularly well. In fact, the drug that she got, Iressa, is now off the market in the US and has been replaced by a similar drug, Tarceva, and I'll tell you a little bit of the story of these EGFR inhibitors. But it's kind of a poetic story of how clinical informations can direct some of the fundamental genetic insights that we get into cancer. It also is an important reminder in that as we approach this era of targeted therapies in cancer, many of these drugs are expensive. Many of these drugs are coming along from a number of different companies without a clear sense of how they should be applied, how they should be tested. And we're looking a little bit at the future of how these cancer therapeutics should be applied. Many of these drugs will have some impact on stabilization of disease. In cases like hers, they really have a magical response. And I think that that's really affected the kind of research that we ourselves have done and the kind of questions that we ask in terms of trying to find out when are you going to have a magical drug like this that may have such a susceptible target, and how can you identify these? So I'll come back to that theme as we talk about EGFR inhibitors. So this is to summarize a lot of work. What we found basically was that there's a subset of lung cancer. It's about 10% of lung cancer in the Western world, about 20% of lung cancer in Asia. And it's a specific type of lung cancer that arises in non-smokers. So if you have tobacco-induced lung cancer, it will have a particular mutation profile with common mutations in RAS and P53. And those kinds of lung cancers will not contain EGF receptor mutations. If, on the other hand, you look at the subset of lung cancers that arises in non-smokers, what you will find is a very significant number of those will have specific mutations, often recurrent mutations, within the kinase pocket of the EGF receptor. So just to recap, the EGF receptor is obviously a transmembrane receptor. It binds to a number of ligands. It has a kinase catalytic pocket, which will bind ATP, or will bind these inhibitors, which are competitive binders to ATP, and blocks their signaling. And these mutations basically activate the receptor and seem to define a specific type of lung cancer, more common in non-smokers, women, Asians, and most typically bronchoalveolar cancers as well. So to summarize this is again going back a couple years of work now. The most significant impact is that patients who have these kinds of lung cancers will often have very, very dramatic responses to EGF receptor inhibitors. You can see within 4 weeks, for example, in this particular case, this tumor, which occluded the entire lung field, has melted away. And in many of these cases, the responses are very, very dramatic. Specific clinical characteristics as well as histological characteristics that define this particular type of lung cancer. So why is it? How does it work so magically? What's the underpinning for this? And I think to summarize, there are three different properties that we now understand about these types of lung cancers that are driven by the EGF receptor mutations. The first is probably the least important but the most dramatic, is that somehow these specific mutations in the catalytic pocket increase the ability of the drug to bind and compete for ATP binding. So it turns out that the mutant receptors are about 10 times more sensitive to inhibition by these EGFR tyrosine kinase inhibitors, or TKIs, than the wild-type receptor. That turns out to be particularly important for wild-type receptors because actually the drug concentration that was achieved with many of these drugs is right at the difference where the wild-type receptor is partially inhibited and the mutant receptor is completely inhibited. But there's more to it than that, and our impression is that it's not just inhibition and the ability of the drug to inhibit at a particular serum concentration. The fundamental pathways of wild-type and mutant receptors are different. And what we now understand is that the mutant receptor, and this is work that's come out more recently from Jeff Engelman and Lou Cantley's lab in Boston, what we now understand is that the mutant receptors actually bind to a family member called ERB3 and signal preferentially to the AKT survival pathways. And this is something that the wild-type receptor does not do particularly well. And that's led to a model which makes a lot of sense, and which is kind of the one that our working model for now, which is that the mutant receptors stimulate a particular pathway which involves survival pathways that are essential for cancer cells to survive. And if you withdraw these pathways, then the cells will undergo apoptosis. So these cancers are, to use the phrase that was coined by Bernie Weinstein, oncogene addicted to these particular pathways. So it's an interesting model that we've obviously studied fairly extensively. But the idea is that some cancers, despite having multiple mutations, will have a particular mutation that drives their survival. And if you suppress that pathway, either by knocking it down with siRNA or with a drug, the tumor cells in culture fall apart and cancers in patients respond very, very dramatically. Understanding the basis of exactly how oncogene addiction works is obviously a very fascinating question, one that we're spending a lot of time on. But the other question is obviously, can you try to identify additional pathways in additional cancers where this might be effective? Now, to summarize the clinical work, the clinical work that has followed a lot of this work has been somewhat confusing over the last couple of years, and I think now we understand this somewhat better, which is that tumors with, the majority of tumors with EGFR mutations tend to respond very quickly, although the response rate for most patients, notwithstanding the one that I showed you, tends to be less than a year, 6 months to about a year response rates, longer if the drugs are given up front, shorter if the drugs are given after patients have received multiple other types of treatment. And then there are a number of mechanisms of resistance that develop and that explain the relatively short period of response to these drugs. This mutation was actually first identified by Barash Homosh, who's actually at Cleveland. I don't know if he's in the audience, but he was in Dan Tennant's lab at Beth Israel at the time. And this is a single mutation right within the binding pocket, which seems to be the single most common mechanism of resistance to this inhibitor. And you can see that this mutation blocks binding to the drug and is associated with acquired resistance. And then more recently, Jeff Engelman, Passayani, and Lou Cantley have shown a second mechanism, which is amplification of another growth factor receptor, which appears to evolve and to confer the survival signals which are deleted when cells are blocked with typical EGF receptor mechanisms, EGF receptor inhibitors. So this is how our clinicians would deal with this, and I just want to summarize this relatively quickly, which is that they would divide the world of lung cancer into two types of lung cancers. The subset with about 10% that has EGFR mutations, or more rarely high-level amplification of mutant or wild-type receptors. These are too infrequent to drive survival in large studies unless the patients are genotyped, and that explains why the drugs have done relatively poorly in this indication in the US. But now studies from our own institution, from Europe as well as from Asia, have shown that if you genotype patients, if you type them for these mutations or high-level amplification up front and treat them with these drugs, there's about an 80% upfront response rate and significantly improved survival. For the majority of patients who have non-small cell lung cancer and who do not have these mutations, then EGFR inhibitors tend to cause disease stabilization ranging from an improved survival of 4 to 6 weeks on average. So it's a relatively modest improvement in survival. It's linked to drug dosage, and exactly how that's typed and how that's predicted is not clear at this point. Now, I want to talk to you about 3 stories, and the first one is particularly suitable for a pharmacology department. It deals with acquired resistance to EGFR inhibitors, work that was done by a collaboration between my lab and that of Jeff Settleman, including particularly work by Daphne Bell, Nadia Godenheimen, and Eunice Kwok. And the idea here is, first of all, this is the resistance mutation that I mentioned that was identified at the BI and Dan Tennant's lab. This is the gatekeeper mutation, and it basically occurs in about 50% of tumors where you can actually find this mutation. It seems to prevent the inhibitor from binding well to the pocket, and again is a missense mutation. The interesting observation that was made was that there are a number of second-generation drugs, and this is one that was sent to us by Wyeth, and now a number of different drugs, which are irreversible inhibitors of the EGF receptor. So this is the structure of Iressa, similar to Tarceva, which is a reversible competitor for ATP binding. And this whole series of molecules have a Michael acceptor, shown here with this red arrow, which will cross-link to a particular cysteine within the receptor and form a covalent bond. That turns out to be particularly important because it's basically a better inhibitor. And what you can see here are cells in which they've acquired resistance to gefitinib, Tarceva, or Iressa. You can see that you can titrate up the drug, and you can no longer suppress activation of the EGF receptor or the downstream pathways, but you can titrate in the irreversible inhibitor, and it suppresses very nicely the EGF receptor as well as downstream AKT signaling, and it kills the cells that were once resistant to the reversible inhibitors. Now, this drug has gone through clinical trials. It has a dose-limiting toxicity. There are new drugs now from Pfizer, from Boehringer Ingelheim, a number of irreversible inhibitors which are now being tested in patients who have acquired resistance to EGFR inhibitors through this particular pathway. And again, we're hoping that these will be very, very promising as second-generation kinase inhibitors. Now, if you model resistance, acquired resistance to these inhibitors in vitro, which seems to be quite predictive of what you see in patients, there's a second phenomenon that you see. So some tumors will maintain activation, and clearly the drug isn't getting to the target and isn't able to block the target. But other tumors in this particular cell line, what you see is somewhat surprising. You can see that in the parental cells, gefitinib or Iressa can effectively suppress the EGF receptor as well as the downstream signaling pathways. But in some cells that have acquired resistance, you can still shut down the EGF receptor, but the downstream pathway is still active. And this is a mechanism that's becoming increasingly appreciated. We've kind of called it oncogene switching. But it turns out that in some of these pathways, the survival pathways are now driven by other signaling pathways. Now, you can look at this. This is a collaboration with cell signaling technologies. It's a particularly powerful high-throughput proteomic scan that they've called PhosphoScan. And what it involves is basically chopping down all the proteins in the cell and immunoprecipitating them with antibodies to phosphotyrosine. So you specifically bring down all the peptides that are activated by virtue of having an activated phosphotyrosine, and then you sequence them using mass spec. And what you can see in this cell, for example, is that there's a whole bunch of pathways which are driven by EGFR, which are now shut down in these resistant cells, and a whole other pathway which now is activated in these cells. And this particular approach enables you to try to figure out which are the particular pathways that can somehow substitute for what was once the dominant EGFR pathway. And the best example of this is, again, the work from Jeff Engelman and Lou Cantley looking at MET amplification as a secondary mechanism, whereby if you block the EGFR pathway, then MET takes over, MET amplification then can drive survival pathways in these cells. The reason this is all interesting is because they're now specific drugs. So if you have an acquired T790M secondary mutation in EGFR, there are now clinical trials of irreversible inhibitors of EGFR, which are now extremely promising in these patients. If you have MET amplification as a mechanism of acquired resistance, there are now a whole series of MET inhibitors, MET kinase inhibitors, that are now being tested in early phase trial. And in fact, you can imagine if they're successful in the future that there will be combinations of tyrosine kinase inhibitors against EGFR and against MET as a way of preventing the development of resistance. So I want to leave this part of the talk with kind of a hopeful message that clearly there's a subset of cancers that are sensitive to these drugs. They don't last forever, and the tumors will become resistant to these drugs, but we're starting to understand the pathways whereby the tumors can become resistant to the drugs. And in some cases, there are new generations of drugs that target these secondary mechanisms, very much along, a little bit slower, but along the same pathway that you've heard previously in CML from Charles Sawyers. Now, I want to come back to two key points in this talk. The first one will be beyond lung cancer. How do we figure out how to get more of these kinase inhibitors and what kind of cancers they can treat? And then I want to come back to this very specific question, which is when a patient with a genotype, when you understand the genetic basis for a cancer and why it should respond to a drug, and it becomes resistant by different mechanisms, how do you know what you're treating? And this kind of comes back to this idea of studying circulating tumor cells. You clearly need to know whether this cancer needs to be treated this way or that way. And we need a better way of being able to know what's happening to a cancer as we're treating it. So let me start with the first part of this, the first new story that I want to tell you. And this is, again, a collaborative effort with a center that we've just established, a Center for Molecular Therapeutics, which is led by my friend and colleague, Jeff Settleman. And the work I'll talk about will be primarily a postdoc in my lab, Gromek Smolik, Alton McDermott in Jeff's lab, and Sri Sharma, a new faculty member in our group. And this idea really came out of a little bit of an epiphany after we had made the discovery of EGF receptor mutations in lung cancer. We went to AstraZeneca, the makers of Iressa, to explain to them the finding. And then we asked them, so now that you know this, what are you going to do with your drug pipeline? You have 200 other kinase inhibitors. How are you going to figure out how not to spend $100 million testing 100,000 patients only to have a drug fail in clinical trials? Is there a better way? And it wasn't clear what that way was. So as Jeff and I were driving home from there, we said, well, you know, if you only knew that 10% of lung cancers actually responded to a drug, you would have designed the trial very differently. You would have genotyped the patients up front and then had a much, much smaller clinical trial of these genotype cases. Is there a way of doing this? And there are many ways of doing this. You could sequence the genome. The problem with sequencing the genome is that there aren't that many kinase mutations. They aren't that recurrent. And there's a lot of background noise. You could do siRNA screens, and that's, again, a very popular way of knocking down different kinases. But the problem is that genetic heterogeneity is the key issue. There's not one kind of lung cancer. There's 100 kinds of lung cancers. To be able to tackle 10% of lung cancers, then you need to be able to test 100 lung cancers. So genetic heterogeneity is key. And what we decided to take this on was to try to see if there was a way of looking at the plethora of drugs coming from drug companies and seeing if we could address the sweet spot or the type of genetic markers that would be useful in terms of targeting these. And this is just to remind me that in 2001, most of the drugs that were coming out from industry were called cytotoxics. In 2006, and even more now, most of them are called targeted agents. Now, I'm emphasizing the called because you can call a drug whatever you want, and many people would disagree on what the definitions are. But clearly, much of the action now is aimed at finding individual targets, finding a small molecule that will attack that particular protein. And then the question is, well, where do we test this drug? So this is the premise of our screen. The idea is that if you could collect every cancer cell line in the world, the entire ATCC collection, the entire European, Japanese, and other types of collections, and you could have all of these different cancer cell lines representing all the different types of cancers, you would basically then have a bank that would represent, to some extent, as much as we can, genetic heterogeneity in cancers. So that's what we did. We've collected 1,100 human cancer cell lines across all types of human types. And you can see the representation. We have a lot of lung cancers. We have a lot of blood cancers. We have less liver cancers. But really, this is a very, very representative approach. And the idea was to grow these in a relatively high throughput format and then interrogate them with different drugs. So you can see you can't do this without a robot. You basically grow them in microtiter plates, and you interrogate them with different concentrations of drug, read out whether the cells are living, and then come out with a particular code to see how they look. And the idea then is really to look for outliers, so to take concentrations of different drugs that don't kill everything, but that might have some specificity. We've tested so far over 100 drugs, some manufactured in academic labs, some from MTAs from companies, interrogating all kinds of different pathways in the cell. And this is what you get. So you get exactly what you would hope. There's a subset of drugs that do absolutely nothing to anything, and we don't recommend that these actually be tested. There are other drugs that will kill everything. You know, bleach is a very effective chemotherapeutic agent, and you kill everything, you can't really go there. But for the majority of these targeted agents, what you see is exactly what we were hoping for. In dark green, you see from 1 to 5% of cell lines are incredibly sensitive to different subtypes of drugs. Most of them are not really that sensitive, and then the bulk of them in white are completely resistant. And there's really no overlap. So what you can see for different types of drugs hitting different pathways, there are different sensitivities. So let's ask something that we actually know something about. What about if we take basically non-small cell lung cancer cell lines and we interrogate them with an EGFR inhibitor, Iressa or Tarceva? What you see is exactly what you would have expected. The cell lines that are most sensitive are the lung cancer cell lines that have mutations in the EGF receptor. And in fact, there's only one of those that has amplification of EGF receptor. Everybody else has a mutation in the EGF receptor. Now, if you ask the question, expand the collection beyond lung cancer cell line and ask of 500 epithelial cancers, which are the ones that are sensitive to EGFR receptor inhibitors, and you get all the lung cancers that I showed you, but then lo and behold, there's a stomach cancer, and that stomach cancer also has an EGFR mutation. And then you have some esophageal cancers that have high-level amplification of the wild-type receptor, and then you have another mutation in esophageal cancer. And the reason this is particularly exciting because it really is taking us a step away from focusing always on the tumor type and focusing much more on the genetic basis or the genotype of these tumors. And in fact, what we now know is that about 10% of lung cancers have mutations in EGFR, about 5% of esophageal cancers have these mutations, about 1% of gastric cancers. They're subsets, and they're relatively rare, and you wouldn't see them if you didn't have those large numbers. But of course, if you are a patient with that particular mutation in your tumor, then we would predict from these functional tests that your cancer will be extremely sensitive to these inhibitors. Now, recently a group in Japan defined a second translocation or an abnormality in lung cancer. This is a translocation of the ALK kinase, which is, again, a kinase that's specifically fused and activated in a subset of non-small cell lung cancer. It turns out that there are a number of good ALK inhibitors in the clinic, and we tested these. And in fact, we found a subset of lung cancers that are sensitive to ALK inhibitors. And again, the most sensitive ones have the specific translocation that was reported in these cases as well. So now we're talking about another subset of lung cancers that can be defined by ALK translocations and that would be predicted to be sensitive to kinase inhibitors targeting ALK. Finally, this is work that was done by Gromek looking initially at MET amplification. MET is, again, a growth factor receptor, very much like EGFR. It's expressed everywhere. It does everything. But there's a subset of gastric cancers that have very high-level amplification of the wild-type MET receptor. It turns out that in these particular gastric cancers, MET is constitutively active. It drives AKT signaling, whereas in the ones that are not amplified, it doesn't particularly direct survival signals in these cells. Lo and behold, if you treat every single one of these gastric cancer cell lines with MET amplification with an anti-MET kinase drug, they all fall apart, whereas the ones that are not MET amplified grow straight through as if there was no drug present. If you ask the same question then with a MET inhibitor in the panel of 500 different cancer cell lines, what do you pull out? You pull out the stomach cancers with high-level MET amplification. But if you then start looking at other tissue types, you'll notice that the most highly sensitive cell line was a lung cancer, again with high-level MET amplification, esophageal cancer with MET amplification, and so on. So again, if you summarize all of this, we can now try to subdivide different types of lung cancers. And again, it turns out that about 10% are defined by abnormalities of the EGFR pathway and are, quote, oncogene addicted to this pathway. And we would argue will respond very, very well to the new types of EGFR receptor inhibitors. There's another smaller fraction of lung cancer with MET amplification that could be treated with the MET inhibitors, which are now in clinical trials, and again now ALK translocations with ALK inhibitors. So if you go along this particular pathway, we would argue that this is a very, very effective way of defining genetic subsets. You're only accounting for here 14% of lung cancer, so we're still only talking about small subsets, but within these subsets, the genetic background makes tremendous sense, and these patients would do well if tested with these particular inhibitors. Now, let me talk about a different twist of this particular story, which is how much can you learn not just about the patients, but about the drugs by doing these kinds of analyses. Now, many of you may remember about, actually almost 6 years ago, a seminal study that came out of the Sanger Center in the UK, which was a basic sequencing effort. And what they found was that about 80% of melanomas have mutations in BRAF. BRAF, again, is a kinase, and the impression was that the majority of melanomas were driven by activation of the RAF pathway, and therefore would be very susceptible to RAF inhibition. The next major discovery was a depressing one, which actually came from a drug company, Onyx, which made a drug against RAF, called sorafenib, which led to a number of clinical trials in melanoma, which were all failures. And basically, sorafenib has now been approved for treatment of kidney and liver cancers, but primarily as an angiogenesis inhibitor, not as a BRAF inhibitor. And the impression was that maybe the whole hypothesis didn't work. BRAF mutations are present in moles on your skin, not just in melanomas. Maybe BRAF mutations don't really matter. Well, it turns out if you have a good BRAF inhibitor, this is an experimental compound from AstraZeneca, what you can see is that if you apply, again, across 500 cell lines, this BRAF inhibitor, you see extraordinary sensitivity for all these melanomas that have BRAF mutations. Not only the melanomas with BRAF mutations, but you'll see the occasional colon cancer, the occasional, I can't read on the slide, but the thyroid cancer, brain tumors with BRAF mutations, all are exquisitely sensitive to this BRAF inhibitor. Now, if you compare the pattern with sorafenib, the drug that was tested in the clinical trials, it actually doesn't hit any melanomas. It actually doesn't work as a particularly good BRAF inhibitor. In fact, it has a completely different spectrum of cell lines that it inhibits. So the lesson that we see is, number one, using this pathway, using this kind of analysis, you can, number one, figure out whether the drug actually hits the target or not. You can compare what a BRAF inhibitor would do compared to sorafenib, which now is understood to be much more of a VEGF and an angiogenesis inhibitor. And secondly, imagine what would have happened if you had done this test, which takes about a week and costs about $50,000, compared with 5 years' worth of clinical trials in hundreds of thousands of patients to figure out whether a drug works or not. So again, we're very optimistic about this particular pathway and this particular platform for testing drugs. So let me summarize this, which is basically the fundamental biological question is that that tumor cell lines somehow, in aggregate, have maintained a lot of the genetic pathways that define the initial cancers. Now, I think tumor cell lines have lots of artifacts. People study them at their peril. But the key point here is in one of numbers. So a particular breast cancer cell line, a particular lung cancer cell line will not recapitulate what real breast cancer or lung cancer is. But 200 lung cancer cell lines or 400 breast cancers will, in aggregate, actually maintain a lot of the patterns that you see in the primary cancers as well. So that a large analysis like this at very, very large numbers of cell lines will actually recapitulate these particular fundamental genetic relationships that underlie genotype sensitivities to these kinase inhibitors. The second point to make is that these are low-frequency events. So the first question was, how many Gleevec are there going to be? How many CMLs are we going to cure with drugs? How many Iristas and Tarcevas will there be? How many lung cancer EGFR stories will there be? There clearly will be lots, but there will not be majorities like this. And you can see from the early sequencing projects from the Vogelstein lab, from the Sanger Center, you can see that kinase mutations are relatively rare. There aren't that many recurrent mutations. And in fact, what we're probably going to be looking at are these low-frequency events. That's very, very frustrating. It means that if you're treating ovarian cancer, it'll be 1% of your patients who will have an EGFR mutation. If you're treating lung cancer, it'll be 10% of your patients. But these do accumulate, and right now it's the best that we have in terms of targeting these kinds of kinase inhibitor trials. We would argue that these kinds of high-throughput trials are very important in clinical profiling new drugs. There are hundreds of drugs coming along from biotechs and from pharma against this target, that target. You have no idea where you should do your clinical trial. And again, this is a very important way of identifying genetic markers and then ideally applying these genetic markers to the clinic. And I don't know if there are physicians in the audience, but this is actually the least exciting part of this, which is how do you bring it to the clinic, and probably the most important as well. We don't have good ways of genetically defining tumors in real time within the time that a patient actually presents to the physician and needs treatment. And again, just think about this. If it turns out that 1% of ovarian cancer has an EGFR mutation, you will never uncover that by treating all patients with ovarian cancer with an EGFR mutant inhibitor and then going back retrospectively to try to figure out if anybody had a mutation. So it's incredibly important to redesign the way that we do these early clinical trials to be able to genetically identify these tumors before patients get enrolled in clinical trials, so you can then apply your drug to the right patient population. So the last part of this talk I want to take you through is a technology platform, which we're very excited about, and about half and every day more people in my lab want to work on this, so pretty soon my entire lab will be working on this. But this is a new platform that came out of an accident. It came out of a collaboration with a bioengineer, Mehmet Toner, who's a microfluidic engineer who is really spending his time trying to purify circulating fetal blood cells in the maternal circulation so as to be able to identify Down syndrome without doing an amniocentesis. Turns out it's actually very hard to find one fetal blood cell in the mother's circulation. It's much easier to define circulating tumor cells in a patient's circulation. So that was basically a collaboration that's gone on for the last 2 years between Mehmet Toner's lab, primarily his postdoc Sunita Nagraf, and groups in my lab, Shamla Maheswaran, who has run the lab, and Lisha Sequist, who has been the clinical point person for these trials. So let me tell you a little bit about circulating tumor cells. Basically, the idea is that you have a tumor, shown here in blue, and that every now and then a cell extravasates from that tumor into the bloodstream and then basically travels through the blood. Now, we don't really know what these cells are. Some of them may be normal cells. Some of them may be cells from the tumor that somehow bleed into a blood vessel which infarcted. Some of these may be metastasis precursors. Some of these may be the so-called cancer stem cells. We don't really know what they are. What we do know is that most cancers kill through metastasis. Most of these metastases are blood-borne, and basically these guys go into the blood supply, come out of the bloodstream, and eventually give rise to metastases. Now, one of the problems in this field is that we know nothing about it. Even the number of these cells, they're reputed to be 1 in a billion cells, 1 in 10 to the 9, is based on the technology that you use to detect these. There's no gold standard, so we don't really know what we're looking for. This is the basic technology that's commercially available now. It's made by a company called Immunomagnetic, and it's marketed through Johnson & Johnson. And it's a very, very elegant technology. What it's based on is the idea of using antibody to EpCAM. EpCAM is an antigen that's carried on most epithelial cells, including most cancers. And then the antibody is conjugated to magnetic beads, so you can purify the cells through a magnetic field. The level of purification of enrichment is about 10 to the 4th, which is pretty impressive, but just not good enough. And the bottom line is the cells are fixed, so they're not viable. The yield is that for most patients with metastatic breast cancer, half of the patients with known metastatic breast cancer have a positive cell in this assay. So it's about 50% sensitive, and the main problem is that the sensitivity is very low. Even though you achieve a 10 to the 4th purification, you're starting with 1 cell in a billion, so you end up with 1 circulating tumor cell surrounded by 1,000 normal white blood cells. So you can't do very much with that. Most of the studies have shown out of 7.5 mils, so it's about 1 cell per cc in lung, breast, prostate, colon, and pancreatic cancer. And because they're so small, it's been used primarily as a prognostic tool. So it turns out that in breast cancer, if you have metastatic breast cancer and you have detectable CTCs, you're likely to not respond as well and not live as long as if you don't have CTCs. But you can't really do much more with this. So this is the technique that was developed by Mehmet. The idea is that you can make a little chip, and I'll show you what this looks like. It's about the size of a business card. You construct it out of silicon. You put in 78,000 little pillars or microposts, and then you cover these pillars with antibody to EpCAM. Same antibody. The idea is that instead of fixing the cells and shaking up the tube, you flow the blood through this particular microfluidic chamber. It's a single step. It's incredibly gentle. This is what it looks like. This is the Rube Goldberg contraption. We have 4 of these in my lab, 4 of these in Mehmet's lab. We're building these as fast as we possibly can. This is what the chip looks like. This is a scanning EM of what it looks like. Now, the cool thing about working with nano engineers is that they actually do lots of equations and have lots of great simulations, and all you get to do is you nod and you say, sure, sure. And then you get to explain it to an audience full of people who probably know more math than I do. Let me summarize the key points. The idea is that these cells are extremely delicate, and many of them are pre-apoptotic. You need to be incredibly gentle to these cells if you're going to be able to capture them. So this is the calculations for how to pass the blood to have laminar flow going through these chips as gently and with as little shear stress as possible. And in fact, most of these nanotechnology devices handle microliter amounts of fluid. This is the first one where you can pour in 4 cc's of blood through this chip in 4 hours. So it's like connecting a garden hose to this microchip. And again, the flow kinetics and distance between these posts and the position of the posts have been optimized so that there's less shear stress than going through the normal heart valves as the cells go through your blood. Now, that's a problem because if the shear stresses are too low and laminar flow is too good, then the cells just kind of sail all the way through. So what they've then done is every 3 posts, every 3 columns, they've shifted the spacing between the posts to cause just a little bit of turbulent flow. And you can monitor this in real time, and you can actually see that that optimizes the chance that a cell will collide with a particular column. You can optimize these with cancer cell lines in terms of the flow rate. You can optimize these in terms of what you do to the blood. It turns out if you lyse the red blood cells, it's not any worse or better than if you don't lyse the red blood cells. That wasn't that impressive to me, but if you actually are a flow kinetics guy, if you have a lot of red blood cells, your flow is completely different than if you just have some cells going in fluid. But it turns out you don't have to do anything to this. You take the blood, you anticoagulate it, and you run it through this chip. And it also turns out, magic of magic, is that this works so well that it doesn't really matter how many antigens you have on the cell surface. The current technology only works with cells that have lots of EpCAM on their cell surface. Here you're looking at different cell lines. These cell lines have high levels of EpCAM on their cell surface. These have very, very low levels of antigen, and the other ones are in between. And it turns out they all get captured with the same efficacy. The only difference is where they get captured. So if you have a lot of EpCAM on your cell surface, you get caught within the first couple rows of the chip. And if you have very little EpCAM, you travel through the chip, and then you get caught towards the end of the chip. Now, the cells are viable. You can stain them with vital dye markers. They're just stuck to the chips. But they're viable, and you can potentially do signaling and other studies with them. And this is the coolest slide. Now, you're looking at tagged cell lines in blood. So there's blood flowing there as well, but you just don't see it. And basically, these guys are flowing, and this guy basically gets caught. You can do this in real time, and you can actually measure how this happens and how these cells get captured. You can watch this over and over again. If you email me, I'll send it to you. You can watch it at home as well. By scanning EM, this is what it looks like. So this is actually a cell line that we spiked in, and in false color, you can actually see the cell caught to it. And this is in even more false color, a real cell from a patient with lung cancer. This is the lung cancer cell right here, caught on this pillar. How do we then quantify these things? So they're captured with EpCAM, which is one antibody, and then we identifying using different antibodies. So here you can see a nuclear stain. This is DAPI in this case, showing that it really is a cell. Here we stain now an EpCAM captured cell with cytokeratin, which is again an epithelial marker. And if we find that this is a cell with a nucleus and it stains for cytokeratin, we call it a CTC. If, on the other hand, it stains for CD45, which is a white blood cell marker, then we call it a contaminating white blood cell. And we can then go to a higher level of analysis. If we take cells from a patient with prostate cancer, we can actually stain them for PSA. PSA is a blood marker as a protein in the blood, but prostate cancer cells express PSA. And in fact, what you can see here, this is the dark part, is the column that's the shadow of the column. You can see the cells with the nuclei stained, and all of the ones in this field stained positive for PSA. And by RT-PCR, you can confirm that it's the right transcript. If you look at a patient with lung cancer, here you have lung cancer cells that are captured in blue here, and in red you can see the lung cancer marker TTF1, which is a marker for lung cancer, and again you can see here the RT-PCR analysis. So we can see specifically that these are not contaminating cells from the skin, they really are cells coming from the tumor. So we've applied this to patients from Mass General's clinics. And to summarize this, we've tested about, so far, 110 patients with all kinds of cancers: lung, prostate, pancreas, breast, and colon. And in 20 healthy controls, we haven't found a single one of these CTCs. In all of these patients with metastatic cancer, we see what you can see, an average of 100 cells per mil. So that's about 2 orders of magnitude better than the current technology in terms of the cells per mil. And in terms of purity, it's even more impressive. The average purity is about 50%, so that it's one CTC with one contaminating white cell, which for the first time now makes it possible to do genetic type analyses because the cells are pure enough. And most exciting here is the few patients, and we haven't done enough of these, we haven't pushed the envelope enough, but these are 7 patients with localized prostate cancer. So these patients did not have metastatic cancer, they were localized and resectable, and all of them had detectable CTCs. So one of the key questions now is how quickly can we push this, how sensitive is the technology, and could this potentially be an early marker? We don't know when patients have CTCs. It doesn't necessarily mean you have metastatic disease. It may simply mean that you have cells that are spilling into the blood supply, and it may have all kinds of implications there. So what we then have gone on to do is to look at patients from the clinic who had different types of cancers and monitor their treatment over time. So these are 9 different patients with different types of cancers. There's basically lung, esophageal, and colon shown here. And we had a blinded radiologist who measured diameters of tumors as measured by CAT scan over the period of treatment that went from 1 to 4 months. And in blue, you can see the tumor volume as measured radiographically. And in red, you can see the number of CTCs over time, again, measured blindly by somebody standing in front of the microscope. Now, these are not perfect, and in fact, because of the way the clinical trial was done, we couldn't bring patients in at the intervals that we wanted. These were all previously scheduled patient visits. So you can see that the intervals are not always identical and not always perfect, but the concordance is actually pretty good. And the more we do this, the more impressive it is right now. So you can see in this case, actually, that the drop in CTCs preceded the drop in tumor volume. Again, in some cases where the tumor grew back, you can see that the numbers went down and then came up again. Now, there are 2 important points here. One of them is that compared to the current technology, we actually have a dynamic range. If you start with 100 cells, if it goes down to 1, it actually can mean something. Secondly, for the non-clinicians in the audience, the way we now treat cancer is that we kind of guess. We take a drug that we think is going to work in a particular type of tumor, and based on that, we offer the patient that drug, and we give it for 2 to 3 to 4 months, waiting for the CAT scan to improve. If the CAT scan improves, you continue with the drug. If the CAT scan does not, you switch to another drug. And the way cancer works, unfortunately, if the drug doesn't treat initially, you don't have that many more times when you can try another experimental drug. Imagine what could happen if within a week or 2 you could find out whether a drug is going to work or not. It really opens a whole new horizon in terms of trials for these drugs if this turns out to be predictive in some way. Now, I want to end, we've been working very much on the genotyping of these cases, and I want to end on this because this is something that we're still ongoing work. But we can basically identify mutations in the blood in patients where we know the mutation that is in their primary cancer. And that takes us back now to lung cancer and EGFR mutations. And I told you that there are a number of different mechanisms whereby patients can become resistant to EGFR inhibitors, the T790M mutation being one of them, MET amplification being the other. We don't typically rebiopsy patients. So if a patient had a particular response and then no longer is responsive, we try another drug. We don't go back in too often and get another biopsy of the tumor to try to figure out what's the mechanism of acquired resistance. And if we did, where would we go? Would we go to one MET, to another MET, to the liver? We don't really know what happens to cancer once it spreads. So the issue of being able to monitor cancer is very, very important as the treatments become more effective. The other problem is that very often what we see now, we've become a referral center for many of these EGFR mutant lung cancers. Very often the initial biopsy was done in another hospital 6 months ago and nobody can find the blocks, or the mutation was done, the biopsy was done with a fine needle aspirates, and there were 12 cells identified, enough to say this person has lung cancer, but not enough to do a mutation analysis. So what we can do now is using this is a particular assay that we're very fond of. It's made by a company called DXS. It's an allele-specific scorpion-type assay. So it's a very, very sensitive PCR-based allele-specific mutation detection system. And what you can see in the CTCs from this patient, exon 2 is the control. You can see this deletion mutation in EGFR is an activating mutation. It's exactly the same one that was present in this patient's tumor, and we can find it in the circulating tumor cells from this patient. And even more importantly, what we can see at a lower allele frequency is this resistance mutation. So it's present at about, we would calculate roughly 1% of the allele frequency of this one. And what we can now see as we do these serial analyses is that these mutations become more and more prominent as the patients are being selected, if you will, with these kinds of treatments. So for targeted therapies, this is going to be particularly important in being able to monitor, essentially know what you're treating at the time that you're treating. So I just want to end with a couple points, which is to summarize why we're so excited about this. We've called it the CTC-Chip. It's kind of a cool name. It's basically a novel technology that gives us about 2 orders of magnitude higher sensitivity and considerably higher order magnitude purity in purifying circulating tumor cells from patients with a broad range of different cancers. And it's a strategy that can be adapted for other kinds of rare cells in the bloodstream. There are all kinds of clinical applications that we're very excited about testing. I've discussed these somewhat, monitoring early drug response in terms of numbers going up and down, but also monitoring them in terms of targeting. Are you turning off the target? Are you hitting the target? Is the kinase being shut off? You could do serial genotyping, as I've indicated. Does the mutation stay the same? If a patient with breast cancer had a HER2 non-amplified breast cancer 10 years ago and now relapses with bony disease 10 years later, how do you know if that disease is HER2 positive and should be treated with HER2 inhibitors or not? Again, the potential for doing this in real time. I haven't talked about this, but we're very excited about the idea of identifying invasive disease. If your PSA is 9 and your Gleason score is intermediate, do you have circulating tumor cells or not? And is that predictive of whether you should have your prostate taken out or whether you should be told to come back a year later and have another PSA measurement? So again, these kinds of identification of invasive disease is very kind of something that we have no idea whether that's going to work, but a very exciting question. And then increasingly, can we push the sensitivity of this for early detection? Is this the way that you could basically pick up cancers relatively early? Finally, this is a whole new field. Metastasis has really been studied primarily in mouse models, and mouse models of metastasis are quite different from human models. There really hasn't been a good way of studying what human metastases are all about. Presumably, if we can release the cells from these chips and grow them, we have a new way of identifying what these metastasis precursor cells are and studying their biology as well, and obviously something that we'd very much like to do. So where are we now? The technology is still in the Group Goldberg stage. MGH has generously donated money for a center for excellence in these technologies. So we've hired more engineers. We're aiming for a little box with a switch, and hopefully it'll be much more optimized. But we've already gone from having somebody sitting through and looking at 2,000 pictures of these 78,000 pillars to having a computer sit down and image all of these various pictures. But it still is a bit of a step in terms of being able to flow the blood through quickly, having enough chips to be able to do the analysis, and then imaging these in a very, very quick turnaround time. We've gone to all of our disease centers and asked them, what's the question in your field that you've wanted to answer? It's interesting what those, if you have time, I'll tell you what those questions are. They're actually not always what you would have expected, but they're all very interesting questions. And again, what are these cells? What are these CTCs? So I'll leave you with these questions and happy to take more questions from you. Thank you.
You haven't identified CTCs. How do you know that about 50% are false positives in white blood cells?
So the question is about false positive and sensitivity. Currently, we don't know. What we know with the current technology is that half of the patients who you know have cancer have cells, and half of them don't have any cells. And when you actually stain the cells with the current technology, and you stain for keratin, for example, 1 cell out of 1,000 will be positive, 999 will be blood cells. So that's how that's defined. In our hands, so far, I mean, the numbers will come down, but so far, the only patient with known metastatic cancer where we haven't seen these cells was one patient with colon cancer where someone dropped the tube, and we only had 0.9 mils. So we're pretty much at the 99%. It will obviously drop, and as we go to earlier disease, we'll have less numbers. But pretty much in every patient with metastatic cancer, we've been able to identify these cells. In terms of purity, we then compare who's positive for keratin, who's positive for white cell markers. And what we clearly see is that if we do the analysis the same day that the blood was drawn, we're at 50%, so 1-to-1 ratios at staining epithelial cells versus blood cells. If we let the blood sit in the fridge overnight, then we seem to activate various aggregation cascades, and all of a sudden the white cells become quite sticky. And we still get the same yield of CTC stuck, but the purity goes way down. And now we're down to the kind of 5 to 10% range. So that's one of the problems with the technology, is that it doesn't travel well. We really need to either find a better way of anticoagulating and preserving the blood so that it can travel, or better, we need to make more of these machines and really make this a point-of-care device where there's no reason why in the future there couldn't be a little black box with a cartridge, and within hours of drawing a blood test, you can actually put it through these devices. That's kind of the way many of these nanotechnology devices are headed.
Is it feasible to isolate the cells from CTC-Chip and culture so that you can test the efficacy of drugs, for example?
So the question is, can you release the cells? And that's something we're working on very, very hard. There are a number of technologies. You can't easily release the antibody from the antigen without killing the cell, but you can play around with how the antibodies are attached to the pillars. And there are a number of different chemical approaches to do that. And Mehmet's lab has been doing quite a few of those. And so far, we're having some good early successes. So we have been able to release some cells. And we're pretty much looking at the microscope every day to see, do they grow? So far, they're not happy. But remember that we wouldn't be surprised if 99% of these cells are cells that are not supposed to be happy. They're epithelial cells. They're in the bloodstream. They don't like being there. It's maybe a very small minority of those that are the true metastasis precursors. So again, in terms of growing these in culture, you need to get the right medium, you need to know what to expect, and we have absolutely no idea. In terms of doing drug screens, we first need to know who's there, because clearly you would want to kill the metastasis precursors. You don't want to be confused by all the other apoptotic cells that are floating around the blood. But that clearly would be the way to go.
Markers to look at the cells in there, and can you see some that have markers for stem cells and some that don't?
So the question is about stem cell markers, and we're looking hard. We haven't gotten there yet. We have all the antibodies in the lab. The question is, if you stain them on the chip, it's a little tricky because you actually have to flow all the reagents through it. It's fairly technically difficult to do the stain. So we have we have PSA working. We have a number of stains working well. We're looking now primarily at apoptotic markers. We want to see how many of these things have divided, et cetera. And we have a number of these stem cell markers to look at, but so far we haven't optimized the assays yet. If there are better ways of releasing them, looking at them on a slide, obviously that will be that much better. We've been told not to get our hopes up because many of the stem cells don't express EpCAM. So if we're capturing them with a differentiation marker, we might actually miss them. And if that's true, we would eventually need a very different type of marker on the chip. On the other hand, we can pick up cells that have relatively low levels of EpCAM, so maybe 1 or 2 little antigens will be enough.
But without even this chip, what you could do is to inject antibody with, let's say, carrying toxin and do this in bloodstream without isolating it. So why not to go that route?
As a way of therapy or as a diagnostic?
As a way of therapy or preventing of metastasis, because that's the way you capture them, right? So you have the antibody. Why not to take that route with the toxin attached to the antibody and kill those cells off?
So the question is, can you make a therapeutic out of our diagnostic? And I think that if you could identify the metastatic precursors and identify a unique antigen on their cell surface, then absolutely. If you're using EpCAM, which is the most common cell surface epitope on all epithelial cells, I wouldn't want to know what happened to you after you got a dose of that. So, you know, it's the key to the diagnostic is recognizing virtually every epithelial cell in the body. It just turns out that they shouldn't be in your blood. So it works in your blood because all the blood cells don't have it, but the rest of your body absolutely does.
How does it compare with fluorescent-activated cell sorting in terms of staining and recovering the cell, the speed and efficiency?
We're testing the possibility of doing FACS analysis as a second step after this. You know, the numbers of cells, we're talking about 50 cells per slide, or 100 cells, or 200 cells per slide. So there's still relatively small numbers. And again, magnetic bead, I think, is probably more sensitive than FACS. So the issues that you get in terms of being gentle to the cells and really being able to capture them efficiently is going to be an issue in terms of FACS. But as a secondary readout after that, if you can release the cells, then absolutely that would be the way to go and the way to ask a lot of questions much more quickly.
So during your talk, you said that potentially an assay like this could be used for early prognostication as to efficacy if we have, you know, different choices for therapy for a cancer patient. However, the numbers in these assays, when I've looked at it, is really small. So how do you think you'll have a confidence level to actually make a choice whether the institution of a therapy within a month is actually really making a difference, considering the small number of circulating tumor cells that one finds in a given specimen? Have you ever looked at it critically, you know, like on a daily basis to see to what extent the coefficient of variation of cell recovery is, et cetera, to use it in that kind of predictive fashion realistically?
Well, I think the difference is that the current technology really picks up about 1 cell per mil, and I don't think that that's useful. There are some patients with the current technology who have high numbers, but they're so few that it's not that helpful. This technology averages about 100 cells per mil. So you're now in the dynamic range, and the more that we're doing now, what we're testing primarily are patients with EGFR mutant lung cancers, and it's really nice. You see them come down very, very quickly, and as the disease recurs, you see them go up again. So we're optimistic that at least with some drugs, you can see a quick response. It may very well be that with other drugs, hormonal therapies, for example, maybe you have a very different time course. So you may have to adjust for the disease as well as for the drug. But we obviously have to do these kinds of trials to see if they're going to be predictive. The next, and we're now setting up these trials to try to do these on every day for the first week to try to see if we can actually get enough points on that curve. The holy grail, if you will, would be actually a marker within the cell, potentially a signaling marker which tells you, did the drug hit the target, did you activate an apoptotic pathway, and is there some signaling readout in addition to just cell numbers? We're obviously not there remotely, but again, there may be some cases where this could be useful.
So it seems like, to me, it seems like looking at EMT markers would actually be ideal, just because you're at that sort of interface or EMT is expected to occur, and later on it reverses. So I wonder if you looked at EMT markers and do you see any correlation?
That's very much the direction that the lab is going. It's the same answer as to the stem cell question, which is that you could argue that we won't pick up any of the EMT cells because they no longer express epithelial markers. They've converted to mesenchymal cells. But we don't know that yet, and we're now testing for all of these because again, it's technically quite difficult to do those cells on these stains.
Sam, everybody's transfixed, of course, with the circulating.
Please ask a question about the first half, otherwise I'll go home unhappy.
Do you know anything about the time course of the EGFR mutations? Clearly, the resistance mutations can arise during treatment. Do we know if the primary EGFR mutations ever arise during the time course of a lung cancer, or do they either have to be either de novo or not? And the question is, when do you know whether you should treat somebody with an EGFR inhibitor? Do you have to keep testing the tumor to see if now that you've given it chemotherapy, there's an EGFR mutation that's important for its survival?
So the question is about the timing of EGFR mutations, and I'll give you 3 quick answers to the different parts of the question. The first is that we're pretty convinced, and there's very strong evidence, that this is a separate type of lung cancer. So it's not a lung cancer that happens to have an EGFR mutation versus a RAS mutation. It's a different type of lung cancer that's defined by these EGFR mutations. When they respond, the tumor melts. When it comes back, but it still has the EGFR mutation, and it accumulates other EGFR mutations, such as the resistance ones. So our impression is that once you're defined as this kind of lung cancer, this is who you are, although obviously your sensitivity to the drugs may be dependent very much by the acquisition of additional mutations, loss of PTEN or other modifying type mutations. So again, that part seems to be consistent. The timing, the 2 things that tell us about the timing of mutations, the first is that there's one family in which basically 4 or 5 family members develop bronchoalveolar cancer. And in the germline of that family, we found the T790M drug resistance mutation, which it turns out is a weakly activating mutation as well. And when combined in cis with a classical mutation is a really nasty oncogenic mutation. And in that family, everybody who was predisposed to lung cancer had the T790M mutation. So at least that's the only family we've ever seen. But at least in that one family, there was a germline mutation in EGFR associated with bronchoalveolar cancers of this particular type. One case, that's about as far as we can go. What I would say is that not our lab, but Harold Varmus's lab and Kwok Wong's lab have generated mouse models where you can actually overexpress mutant EGFR in the lung, and clearly you get lung cancers based on that. And when we actually look at patients with lung cancer who have metastatic lung cancer, their tumor as well as all the sites of metastasis have the same mutation. So based on that, we don't think it may not be the initiating mutation, but whenever it happens, it takes over the population, and the tumors clearly become dependent on that, because if you take it away, they melt away. Great.